Thank you, Prem, and thank you to the organizers. I'll just go straight to the talk. That's about management of malignant arrhythmias. Now, by malignant arrhythmias, I mean arrhythmias where the patient is collapsing in front of you, or it's almost collapsed, or there is severe heart failure or angina. Or I would also say arrhythmias where we are given a particular, the arrhythmia is not responding. I would classify that also as malignant. Now, before I go into the arrhythmia, do not forget, don't waste your time looking at the ECG. Is it P? Is it QRS? Is it AV dissociation? Don't do that if the patient is sick. If the patient is sick and if there is a tachycardia, shock the patient. If the patient is sick and there is a bradycardia, give atropine or CPR. And then look at the ECG. Okay, so the patient is more important than the ECG. And second is, while you're treating the arrhythmia, also try to figure out the underlying condition and treat that. Having said that, I'll get to the arrhythmias per se. There may be malignant bradyarrhythmias or tachyarrhythmias. Bradyarrhythmias, where the patient is virtually collapsing, the first thing to do is start CPR and then think. Okay, give atropine while you're giving CPR, and then you go to temporary pacing. It's a good idea if you have transcutaneous pacing. In the some of the defibrillators do have transcutaneous pacing. Don't forget that. If the patient is having very severe symptoms but is not really collapsed in front of you, it may be sinus node dysfunction or AV block. Sinus node dysfunction, start with atropine. You don't have to jump to temporary pacing. You can give isoprylene infusion. Don't think too much. If you can't see the QRS, call it ventricular fibrillation and give a full energy 200 joules biphasic asynchronous shock and then think what it was. If the QRS is very well visible and it's a wide QRS tachycardia and the carotid pulse is palpable, please don't waste your time trying to figure out if it's VT or SVT if there's very severe symptoms. The treatment is same. The treatment is a synchronous cardioversion, not asynchronous. What's the difference? In synchronous cardioversion, you press the sync button, look for these markers coming on top of the QRS. If they don't come, change the lead to make sure that they come. And then you give a synchronized shock. So this is a synchronized shock. There are markers on the QRS. You can see that the shock is delivered the moment the QRS has come. The difference, and this of course is a supraventricular tachycardia. The difference between that and an asynchronous shock could be this. If you end up giving a shock in the appropriate point of the T wave, you could induce ventricular fibrillation. Don't panic if it happens, give a second shock, it will go away. But if you give an asynchronous shock for an organized rhythm, you can end up doing this. So press sync and make sure that it does sync. Now, the third part, you're not sure of the QRS or you're not sure of the carotid pulse, give an asynchronous shock of 200 joules and then think. The situation where you really have to think, it comes back to what I told. Treat the patient and not the ECG. The patient looks stable, but the ECG looks like this. This is not ventricular fibrillation. This is not polymorphic PT. No patient can be stable with this ECG. So if you have a stable patient, but the ECG looks rather unstable, it is an artifact. The clue is that if you look very closely, you will be able to pick up these QRS complexes at regular intervals within that unstable looking ECG tracing. Now, so we come to the near collapsing tachyarrhythmias. What about the tachyarrhythmias where this patient is not collapsed but has severe symptoms? Please record a 12-lead ECG. Do not take a monitor strip and then treat because then you don't know what it was. So record a 12-lead ECG. It might show a regular narrow QRS tachycardia, which you diagnose as SVT. The management is adenosine. Remember, the dose is 0.1 to 0.3 milligram per kilogram. It can range in between any of them. And please record an ECG during adenosine, not before adenosine and after adenosine. So here's the importance. You record an ECG during adenosine. In these two strips, you can see that the adenosine has stopped the P wave from forming. So this could be an adenosine sensitive atrial tachycardia, or it could be a situation where adenosine is blocked conduction from the QRS to the A, that is through the AV node. So it could be an AV node dependent reentry. Either of these can be an AV node dependent reentry or an adenosine sensitive atrial tachycardia. But the importance is this. See, this is a tachycardia which has not responded to adenosine in the sense that in this tachycardia, if you record before adenosine, it's tough to make out what it was. But during adenosine, you can clearly see the P waves and the QRS. You know that it's an atrial tachycardia or an atrial flutter. But if you record the ECG a minute after this, the ECG will look exactly like this. You will not know what it was. So that's the importance of recording during adenosine. You know what it was. What if you think it should respond to adenosine, but it's not responding to adenosine? Give 18 mg after cutting down all sympathetic stimulation. That is, after sedating the patient deeply, give the same adenosine, it is bound to work. And what if it reverts with adenosine but comes right back? So then the next thing to do is start an infusion of diltiazem and then give a bolus on top of the infusion or give the adenosine on top of the infusion. That is likely to work if it has once worked with adenosine. What if you have an irregular narrow QRS tachycardia? There are only three diagnoses: atrial fibrillation, atrial tachycardia, or atrial flutter with irregular AV conduction. We have two options: chemical cardioversion or electrical cardioversion. For chemical cardioversion, we have amiodarone and Ibutilide. When do you use either? Well, if there is no hypotension or heart failure, we could either go for chemical cardioversion or electrical cardioversion. But remember, in both of them, the first step is to check for a thrombus. And if the patient is not anticoagulated, give heparin. And remember, whether you pharmacologically cardiovert or electrically cardiovert, you need anticoagulation. That is, you see a patient with atrial fibrillation, fast rate, don't jump to amiodarone before giving the heparin. That's what I'm trying to say. If the BP is reasonable, it is okay to give amiodarone. But if the BP is low or borderline, please do not give the amiodarone bolus. If you want, you can give the amiodarone infusion, but please do not give the amiodarone bolus if the BP is borderline. If the BP is perfectly okay and the LV and the RV function are normal, Ibutilide may be given. Personally, I found that amiodarone works better for atrial fibrillation and atrial tachycardia, and Ibutilide is superior to amiodarone in cases of atrial flutter, especially if it's a typical atrial flutter. If the blood pressure is low or the patient is in raw CHF, it's cardioversion. And before cardioversion, start noradrenaline because you need sedation for cardioversion, and sedation will drop the blood pressure further. What about Ibutilide? So the dose for an average person that is more than 60 kilogram is 1 vial over 10 minutes. If the person is less than 60 kilogram, it is 0.1 ml per kilogram given over 10 minutes. If you want the dose in milligram, that's a dose in milligram. If it's not so what I was trying to say is if it's a non-hypotensive atrial flutter, the first option would be Ibutilide in a normal heart. Second option would be cardioversion. And third option would be amiodarone. Amiodarone is a rather poor drug for conversion of atrial flutter. The beauty of Ibutilide is you can just stop it here without giving any sedation, but it is just like amiodarone. It can cause polymorphic VT in LV dysfunction or structurally abnormal hearts or in presence of hypokalemia. So don't use it. What about a malignant arrhythmia which has been diagnosed as a ventricular tachycardia and the patient has reasonable blood pressure? You can give the amiodarone just like the SVT, but give amiodarone plus beta blocker and then consider cardioversion. Also look for triggers, hypokalemia and ischemia. Remember that troponin can be positive due to VT-induced hypotension or cardioversion or due to ischemia. That is to say, having a positive troponin with a VT doesn't mean that ischemia is cause of the VT. If ischemia is present, it's very difficult if the ischemia is the cause of the VT. It's a very difficult decision. I'm not going to discuss that here. That's not the point of this talk. So this is a situation where you have a polymorphic ventricular tachycardia. You first cardiovert, of course. And after that, you see, what do you see? You see a very long QT. So in this situation, you correct the underlying condition. You maintain potassium 4 to 5, stop QT prolonging drugs. You can empirically give magnesium and avoid large negative fluid balance. Avoid large doses of diuretics. They can further cause intracellular hypokalemia, which might take some time to reflect in the serum potassium. So don't give large doses of diuretics in this situation. What if the arrhythmia recurs? SVT, consider ablation. What if VT recurs? Refer for ablation. Please note the choice of words. SVT, consider ablation. VT, refer for ablation. Don't keep thinking, I will cardiovert again. Don't keep thinking, I will give amiodarone again. No, you might get into trouble. If you get a small window of stability in VT, send the patient to a center which can ablate if it's a recurrent VT. And keep the defibrillator patches connected if a VT recurs in a patient. Frequent PVCs triggering non-sustained VT or VT in presence of long QT. Do not miss the long QT in the sinus beats. Then you cannot use amiodarone. You have to use lidocaine. What if the arrhythmia doesn't respond to cardioversion? You need an emergency ablation. Now, what if you can't do an emergency ablation? Most centers can't. Well, if you can't take care of the heart, take care of the sympathetic stimulation to the heart. So there's a massive amount of sympathetic stimulation to the heart, but essentially it works at 3 levels. Sedate the patient so the outflow from the brain comes down. Knock off the T1 to T4 by thoracic epidural anesthesia, or knock off the stellate ganglion because most of them finally come through the stellate ganglion and T1 to T4. So how do you do the sympathectomy. Either it can be done percutaneously or it can be done by thoracic epidural anesthesia at the T1 to T3 level in a cannula. So this is the dose. It's bupivacaine being given at this dose. Surgical, of course, is not part of this talk. What do you do? How do you do it percutaneously? I think every person who manages a lot of arrhythmias should know how to do this. It can be done on the bedside. So the stellate ganglion is right here in the anterolateral vertebral border, just next to the longest collar. So how do you reach there? You can actually do it blindly. Just palpate the carotid tubercle, pull the sternocleidomastoid away, stick a needle right down till you hit the trachea, till you hit the vertebra, not the trachea, till you hit the vertebra, pull the needle back slightly, and gently you will be there. If you don't want to do that, well, this is how it is done. Of course, you could injure the vessels, so you must aspirate to see, not aspirating blood. But if you have access to fluoroscopy, you can do it under fluoroscopy, or if you can access to ultrasound, you can do it under ultrasound. Fluoroscopically guided, so these are the landmarks. That is the anterior, so just anterior to this foramina in the C6 and C7 vertebra. You inject at this level, it will flow down to the stellate ganglion. So this is how it's done fluoroscopically. You push the needle. This is done at this is at C7 level. It should be done at C6 and C7. You push the needle till you reach the anterior part of the foramina, and then you hit the bone. And once you hit the bone, you stop pushing the needle. Then you inject a tiny ml of contrast. Visualize the contrast spreading supro-inferiorly. So you know you're in the sheath of the longest colli. And then you inject about 3 to 5 cc of 0.25 cc of bupivacaine. The effect is usually, it can be done by stellate block, ultrasound guided also, where if you can see the carotid artery, the sternocleidomastoid, and the longest colli muscle. The only tough part is to identify the transverse process of C6. The anterior process is longer than the posterior process in C6. You need some expertise in doing this part. The vessels are easily identified.
Dr. Ajit, if you can finish in a minute, that'll be fine.
So I will stop with that, and I hope I have covered, very quickly all the malignant arrhythmias that you're likely to see in front of you. Thank you.
Thank you, Dr. Ajit.